Hi, everyone. Welcome in. We are so glad to see everyone in here with us tonight. Another AOSH webinar, another one for this year. Guys, if everything works out this year, we are hoping to have over 30 webinars this year, if everything works out. So that's 30 CE credits that you will be able to earn this year if you're a member with this organization. As you're coming into the room tonight, be sure in the chat to tell us where you're from, who you are. If you want to give a shout out to your dental practice or to your medical practice, go ahead and do that. We would love for you to tell us all that information. We always love to know where members are from, and where you're dialing in from tonight. We always love to see that. I'm actually supposed to be in Clarksville, Tennessee. I am not. I'm sitting in New Orleans right now, trying to figure out where we're going to have our 2026 annual session. So we're super excited about some of the opportunities that are out there and can't wait to make an announcement here. Hopefully, by the first couple of weeks of June, about where we're going to be. This is just one of the many cities that we're looking at, and we're super excited about what the next couple of years and even further down the road is going to hold for us. So we're going to get started. We're going to let a few more people trickle in. Be sure while we are having our great webinar tonight that you use the emojis, that you use the chat to ask questions. Don't be afraid to chime in. We always love to see what everyone is saying, and we want you to be involved. It helps our speakers know that you are in agreement, or that you find their comments funny, or something that they say that you want to chime in and have some little way to be a participant. Always do that. We love to see the reactions, and we love to see everyone participate. So with that said, let's go ahead and get started. So tonight's webinar, as you can see, we're going to talk about, hold on just a second. Actually, I think, Danielle, we didn't change the title on that one. Go ahead and switch over. Actually, our webinar is going to say it's a different title, but we'll get there in just a minute. Let's go ahead. Actually, that is correct. It is New Trends in PRF Therapy in Implant Dentistry, Periodontology, and Facial Aesthetics with Dr. Miron and Dr. Estrin, who are going to start with us in just a minute. So let's go on over to our next slide, which is, I'm sorry, I'm lost about 2 weeks behind where I'm supposed to be. Let's talk about annual sessions. So was just in Dallas literally on well, last week I was in Dallas and got to go down to the Cooper for a few minutes, the Cooper Hotel Convention Center and Spa, where we're going to have our show. It's going to be such a great show. We signed a contract while we were down there. We're going to have a gala on Friday night that's going to blow your socks off. We are so excited about this gala. It's going to be at a place called the Austin Ranch. That's a little dude ranch it's in the city of Grapevine. We're going to provide transportation to it. Guys, I'm telling you, it's going to be a beautiful experience. We're going to call it AOSH Stars Over Texas. Going to have some exciting music, presentation. I'm telling you, it's going to be beautiful. It's going to be one of the first times that we've ever had a sit down dinner in a little while with you guys. You're going to have a chance to get to know people, network, and get to have a really fun time with a lot of your friends that you don't get to see all the time as a part of this. But we're really excited to make that announcement. We can't wait to see you in Dallas. I'm so excited about this event. And hey, Gennady, welcome in. So excited to be a part of this. And we we can't wait for you to see what's in store in Dallas. We have so many exhibiting partners that are going to be a part of this, and we can't wait for you to join us. If you have not gotten your ticket yet, you need to get it. We are
We
running out
sold
of
past
tickets.
half now.
Yeah, I
Yeah.
mean, we are well past the point where you're going to wish that you had gotten a ticket if you don't get one soon. I keep saying that. We are now in our overflow hotel over at the Hilton Lincoln Park. We are sold out over at the Cooper Clinic, but no fear about that. Inked a transportation deal just this week too, so you will have transport, not a tiny shuttle, but a good mid-sized shuttle that can take you back and forth as you need to go from the Hilton to the Cooper. So no worries about that. We've got that covered. There's no excuse for you not to join us down in Dallas. You need to come join this. We've got great speakers. Dr. Chris Kammer is going to be on stage. Dr. Ellie Campbell, Dr. Thomas Levy, Kristen Reisner. I could go on and on and on, but we do have a full schedule now available too on our website for you to take a look and see who's going to be speaking with us. So don't wait. You need to get your tickets. Join us in Dallas. I can't wait to see you there. And I can't wait to share with you all the fun things that we have in store for you as you join us at the Cooper Hotel, Conference Center, and Spa in Dallas, September 11th through the 13th. So come join us and don't wait on that ticket. Danielle, if you'll go on to the next slide for me, please. So this is our conflict of interest statement. I don't want to hold this up very long, so we'll go on through the next one. This is our course information. This is our accreditation, credit, and support statement. This is our disclosure of unlabeled use. This is our disclaimer. This is our method of participation. This is our course description, which we sent out to everybody who signed up for the webinar, and it's been on our website for a while. These are our learning objectives. This is our practical applications. And I'm going to go ahead and introduce each one of these speakers to you tonight. We are so excited to be able to introduce to you two members of our advisory board, Dr. Richard Miron and Dr. Nathan Estrin. Dr. Miron is a globally recognized expert in regenerative dentistry and biomaterials with extensive training in periodontology, cell biology, implantology, and facial aesthetics. He holds multiple advanced degrees, including a PhD in periodontology from the University of Bern and a DDS from Laval University. Dr. Miron has served as faculty at institutions worldwide, including the University of Bern, the University of Michigan, and Nova Southeastern University, and is currently the founder of Care Esthetics in Jupiter, Florida. With over 300 peer-reviewed publications, numerous awards, including the prestigious ITI Andre Schroeder Prize, and leadership in advanced platelet-rich fibrin PRF education, he is a leading force in translational research and clinical innovation in dental medicine. And Dr. Nathan Estrin is a board-certified periodontologist based in Sarasota, Florida, with a strong background in implant dentistry and periodontal therapy. He earned his DMD from Lacombe School of Dental Medicine and completed his residency in periodontology at Stony Brook University. A passionate researcher and educator, Dr. Estrin has published extensively on topics such as lasers, periimplantitis, platelet-rich fibrin (PRF), and exosomes. He serves as an adjunct faculty at Lacombe and the University of Iowa and is a lead educator for PRF EDU. I am proud to say again that both of these men are members of our AOSH advisory board. We are excited for everything we are going to learn from them today. If you have any questions throughout this presentation, please drop them in the Q&A box and we will cover them at the end. So without further ado, please join me in welcoming Dr. Miron and Dr. Estrin. Gentlemen, the floor is yours.
All right. First and foremost, thanks so much for the introductions. It's really an honor to be here, to be part of the board, obviously, and to be doing this lecture with my best friend, Dr. Estrin. So he and I have worked together in private practice and do a lot of work in this space. And I also want to thank Gennady for connecting us with the group. I wanted to change up my presentation. A lot of people have probably heard me speak quite a bit. I know Dr. Estrin can certainly present the clinical applications of PRF a lot better than I can. But I wanted to focus on, really understanding the importance of the immune system. And I think, the group at AOSH is really into holistic health, trying to do what's right for your patients, et cetera. So I kind of want to share some of the, breakthrough research we've been doing in that space there. I'll introduce PRF protocols, obviously, and then Dr. Estrin will cover the clinical applications of PRF and how we use some of the co-biomaterials. All my slides, I'll send them to you after the course, Violet. So if anybody wants any of my lecture slides, etc., Dr. Estrin and I are open books, and we'll send those out so you guys have them as well. So for those that have never met me, I spent a lot of time in Switzerland. I worked with these two fascinating gentlemen. In fact, we were all with Tony Scullion last week doing a hard and soft tissue PRF symposium with Dr. Estrin, and did a lot of work with growth factors over the years. And Dr. Boozer did a lot of work in implant dentistry. So I always like to acknowledge my mentors. And when I moved back to North America, I established myself at Nova Southeastern University, and I worked at the Center for Collaborative Research, trying to understand biomaterials and bring these biomaterials to market. In the year 2019, we wrote this book on next generation biomaterials. I always tell clinicians, before any biomaterial dental implant is brought to market, we have to do years and years of research preclinically. And so things that Dr. Estrin and I, for instance, are always testing new things. We're testing exosomes in vitro, in vivo, in clinics for the very first time before they're ever FDA cleared. So in order to get a material brought to market, it literally takes 4 to 5 years to go through that process. And I wrote this book to try and help colleagues out to really understand these different biomaterials. I was very shocked. I was in my mid 30s when I wrote the book, and it was the most sold textbook in the world. And it really gave a big platform for, us to teach in different organizations, universities. Dr. Estrin's a faculty member at several different universities as well. And so he and I try as much as we can to share the passion to get, more periodontists to do research as well and to try and advance the field. So when we talk about, biomaterials, it's really important to understand that, when we put something in the body, it's not a happy place. Like if I put a dental implant into somebody's body, this is not a happy place where there's bone cells that just go in there and they make bone. And it's not like that at all. In fact, it's all governed by your immune system. And so the first cell types that come in contact with any biomaterial are going to be monocytes, macrophages, and those are the cells that are going to be responsible for dictating whether or not they call in, osteoblasts to make new bone, or they say, we don't like this dental implant, fibrous encapsulate it, spit it out of the body. I want nothing to do with this. And about 10 years ago, we started to realize that if these macrophages, especially, were not healthy, integration of biomaterials was much worse. So before we talk about PRF or exosomes or bone grafts or implants, we have to understand how important these cells are. And what we've learned more recently, and Dr. Esther and I are writing a paper right now for the top dental journal, Periodontology 2000, looking at specifically vitamin D deficiency and the impact on implant osseointegration. And so we're going to cover this in great detail. This is the gentleman who won many awards related to being the first person to figure out that macrophage polarization is really what's important on these dental implants. And so he did this work many years ago. It's been a decade now. He's won many international prizes related to this. And back in 2010, 15 years ago, we realized that bone formation is preceded by macrophage accumulation on dental implant surfaces. So very important that these cells are very, very healthy. He won major awards related to the work that he's done. When I talk specifically about macrophages, they're very plastic cells, which means that they can become one cell or another in the sense that they can be happy, they can be upset, and they switch very, very quickly. And so in science, the way that we refer to macrophages, when I say M2 macrophage, for instance, that's a happy cell. And that's the one that's going to help with immune suppression and tissue repair. If I say it's an M1 macrophage, this relates to tissue injury. So that macrophage can either be, happy or sad. They make jokes here, the dark side or the Jedi Order. But in a nutshell, we're trying to get as many of these cells to become M2 macrophages. And we'll talk about links of how vitamin D is so relevant in this space. And work many years ago by Spiller and his colleagues, they found that these macrophages in vitro, they can shift from unhappy. So in a research lab, if we give them LPS, they become unhappy. If we give them certain types of interleukins, they become happy. And you can flip them back and forth within 3 days. So the reason why I'm showing this is this relates, to, for example, periodontal disease or periimplantitis. Things can be really unhappy right now, and within 3 days, you can do a cleaning, you can do proper rinses, that are more homeopathic. You can increase the supplement dosing, and within 3 days, the whole body can then turn happy. So very, very important to understand, what we're capable of. And what we've learned in the dental implant space is that when we start to have unhappy cells around implants, and we call these, you see them here, FBGCs, these are multinucleated giant cells, basically. And this right here will accumulate a lot of inflammation and will cause very quick breakdown. And Today, we've learned how important these are. We've learned about titanium particle release and what effect that has. And this was the gentleman who really in the implant dentistry world started to show people that, you know, implants are very different than teeth. And in the implant world, you can have marginal bone loss very, very quickly. And unlike teeth, it doesn't have to be related to infection. And so we always thought, these papers are old. They're almost 15 years old now here. This group was the first to show that if you look at cases with excess cement around implants, this is no infection whatsoever, but you have tons of bone loss very quickly. And so it started to make people think this is really related to the immune system, and we have to, control the immune response. In this case here, the excess cement caused the immune system to become unhappy. That shifted macrophage polarization towards M1 macrophages, and then all of a sudden you have a lot of breakdown. Okay. And they even question whether periimplantitis is a foreign body reaction or a man-made disease. And so, they really showed as well when they looked at orthopedic implants, and this was really the paper that made it very, very clear. They said, unlike dental implants, orthopedic implants are not in the mouth. There's no transmucosa, so there's theoretically no bacteria here. But when an orthopedic implant starts to break down, it starts to break down the exact same way as a dental implant. Bone loss marginally around the sides, and then slowly but surely, bone loss keeps going. And then all of a sudden, the thing pops out when there's more than 50% bone loss. And there's no bacteria here. It's entirely immune related. And even in their fields, they start to look at, reasons why orthopedic implants start to fail and the links between vitamin D deficiency, for instance, and hip failures and knee failures, et cetera. So that's very common in other fields. And, we're doing work in the dental space. And so, very importantly, I'm sure a lot of you guys are using zirconia implants, but a lot of literature has been written on metal particle release and just titanium corrosion. It's not a topic that I want to cover in much detail, but a lot of literature exists on that. And we also know with gum disease that it's becoming a bigger and bigger problem, of course. And we've established, as periodontists, mainly in the perio field, links between periodontal disease and all of the above. So whether it's diabetes, arthritis, heart disease, osteoporosis, Alzheimer's, et cetera, there's links between all of these. And, if you were working in the perio field 40 years ago and you were a periodontist and said, we got to clean your teeth and get rid of your perio disease because it's going to give you a heart attack or give you Alzheimer's, your patients would look at you like you're crazy. But today we've realized that what happens is there's inflammation that's created in the mouth. It shifts the immune system to be more M1 polarization. So that's the inflammatory state. Inflammatory markers are getting secreted throughout your body. And now your entire whole system is now in an M1 inflammatory state. And when that happens, there's just a whole slew of problems that happen thereafter. And that's the reason why when somebody gets sick with one issue, there's a whole bunch of other problems that can occur. And so what we try and do is we try and reverse this. And really, if we were to explain this in scientific terms, the inflammation that's caused in periodontitis, this is immune system dysregulation between the M1 and M2 macrophages. And there's a lot of work that's being done at Harvard right now. These are two gentlemen. They work with resolvins. They've done a lot of research to figure out ways to lower this inflammation and small little biomolecules that they're creating in order to lower this. I spent a year at Michigan in the year 2016, and when I was here, we started to try and understand better why do we have dental implant loss. So example, what can I do, or can I use PRF to try and fix this problem, or can I use exosomes, or what are the links that we see so far with early implant failure? It's the implants that you place. You don't know why, but 3 months later, 4 months later, it's a spinner and it comes out of the oral cavity. And in 2016, we looked at all the literature, and even back then, we realized that one of the reasons was low vitamin D intake. And we talked in this paper about how these cells and the immune cells are being discussed as key regulators during osseointegration and maintenance and how important this is. So I was very shocked because I got an email one day. It said, "Congratulations. It's one of the top downloaded articles in recent publication history between July 2016 and June 2018. And so we realized that, our colleagues wanted to learn more about this. We understand how important vitamin D is. It's obviously the vitamin for bone, but more importantly, it's one of the most important vitamins for the immune system. And so, oddly enough, there's links between vitamin D deficiency and all of the following: Alzheimer's, asthma, cardio disease, depression, diabetes, multiple sclerosis, Parkinson's. And when you see this, it's almost exactly the same links between periodontal disease. And the reason why, it's the exact same thing. When that immune system is flipped, and when it's flipped negatively in the M1 phase, it doesn't matter if it comes from your perio disease, your periimplantitis, it comes from vitamin D deficiency, comes from diabetes, it doesn't matter where it comes from. But when that happens in your system, in your body, there's a whole slew of other problems that happen thereafter. Um, Specifically to implant dentistry, there was many studies that looked at vitamin D and bone physiology. So in these cases here, they literally take dental implants in this rat model and they put them in bone and they do what's called a pull-out test. So they actually try and rip the implants out. And depending on that strength, that's how we know if the implants are well integrated. And in the animals that are vitamin D deficient, they lose 66% of the original strength. So these implants are only 33% integrated, so to speak, and many links now exist between vitamin D deficiency and early implant failure. Interestingly enough, work that was done showed that if you simply what we see here, if we simply compensate by vitamin D supplementation, you could restore the bone implant contacts back to normal. So the nice thing about this problem is that we know in our population a lot of people have vitamin D deficiency, but we also know it's a very easy fix and it's not a very expensive fix. So we'll talk about solutions later of what we can do with our patients to try and help them. About 10 years ago, clinicians started to write these paper and they started to say, we believe vitamin D deficiency is a suspect factor in the failure of some of our immediate implants. And case reported started to be published. More and more literature existed, vitamin deficiency and early implant failure, more case reports. And then this very large scale study came about, and low serum vitamin D and early dental implant failure, is there a connection? The reason why this paper was so well received, it had almost 2,000 implants with almost 1,000 patients in the study. And what they found, which was very interesting, overall, there's a 4% implant failure rate. In heavy smokers, defined by 15 cigarettes or more per day, at 6%. In generalized perio, 6%. And then those that are vitamin D deficient, 11%. So it was three times worse. And the risk factors for early implant failures were highest in vitamin D deficiency when compared to anything else. And so before we start talking about all the fancy biomaterials and the work that we're doing, it's critically important that we understand that unless the host, unless that person and that person's systemic health is optimized to receive these dental implants, we're going to have a lot more failures. And this message right here is much more important than using PRF, for instance, or using exosomes, etc. This is the article that we're about to publish. Amazingly, there's been over 45 different studies that have looked at the relationship between vitamin D deficiency and implant osseointegrations. We were asked to write this paper. It's going to go in Perio 2000, which is the #1 ranking dental journal. And myself and Dr. Estrin are working on that actively every day. Um, as I mentioned with vitamin D deficiency, it was interesting during COVID. That's when the CDC started to publish these things like fun facts. Vitamin D deficiency is a global pandemic. Coronavirus is spreading. Vitamin D is a powerful immunomodulator. We lose nothing by supplementing, so on and so forth. Many people are between 3 and 20 nanograms, and nobody is above the 40 nanograms, which is where we like to have our patients. Obviously, as dentists, we follow the guidelines by the Endocrine Society, and the guidelines for vitamin D that were published some years ago. So the Endocrine Society, they say that you should be above 30 and more preferred range between 40 and 60. All adults should be taking at least 2,000 units. But when you're deficient, then you need to start taking 5,000 units per day for 12 weeks if you just do vitamin D. And we'll talk about strategies for how we can shorten that with some of the cofactors and get that to a 4-week period where we like to supplement patients. Um, Interestingly, as well, there's an ability to actually check vitamin D levels right in an office. And so this is a tool that was pioneered. There's one company in Europe that developed this, and there's also one company in Canada, but it's a simple finger prick. So what you're going to see here and the way it works, and this is from years ago, it almost looks like a COVID test, but you take a sample of blood and you will then mix it with the buffer that contains the antibody. You shake that up and you just put it in this little strip, which actually looks like a COVID test. But instead of measuring, you're positive for COVID or negative, this has to measure the levels. And so in order to do so, there's a control band and a test band there. And over time, we have a little cube reader, and the cube reader is literally going to scan it. So it takes 15 minutes. It just counts down nice and slowly. And then by the end of this test, okay, you'll see vitamin D 50.2 nanograms per ml. So I know this patient's between the 40 to 60 range. We're ready to do surgery. Okay. We don't do surgery on anybody that's deficient. It's just a bad idea because of all the links. There's also an importance for antioxidants, a lot of literature on that as well. I don't want to go necessarily through all the studies, but it's been known for many, many years. And these are well-known periodontists here, Pat Allen and some of the others. In general, we need to have, decent levels of antioxidants prior to doing surgery or to treat periodontal disease. I'm going to show some systematic reviews in this place as well. But for many years, people have talked about micronutritional approaches to periodontal therapy and how to treat these patients. And so in the medical space, there was a product called Vivita Medica, and medicine used this product to try and recover patients, mainly in plastic surgery. And unfortunately, it does not have very high vitamin D levels. And because of that, we've been able to create with several colleagues a product that is going to be more specific for dentistry. That product is called Dentamedica, and that's the product that Stella Life carries. We've done research with it. I'll showcase some of the papers we've done with it as well. But very popular, in medicine, they've been doing these supplementations for more than 20 years. Very few dentists actually think, outside of this oral cavity. I mean, AOSH is probably some of the top group it's probably the top group actually that really thinks systemically. But even when I talk to a specialist like a periodontist, they're focused in here. I mean, this is the only thing they care about, this little 3 inch by 3 inch or 4 inch by 4 inch window. And that's all they care about. And people forget how important the rest of the body is. And here we see the US deficiency of vitamins. Vitamin D, the vitamin for bone, is the most deficient vitamin that we have. And that's the most important one when it comes to implant dentistry, treating periodontal disease, et cetera. So very important here. We've done a lot of research now with Dentamedica. Very important are these antioxidants as well. And some of the studies that we've done, we've used scanners that you can actually measure antioxidant scores. I'm not going to go through all the work that we've done to showcase this, but this was a study that was done looking at supplementation with Dentamedica prior to implant surgery. And we did this in collaboration with the White Clinic and with Dr. Paz and Dr. Miguel Stanley. We actually checked the two testers versus just doing a regular blood test to see how efficient these little devices in office were. So we were curious, like, well, what if the readings are not correct on these little cube readers, right? So when we did this, the blue here is a lab score. This is the first finger prick test in orange, and there's the gray one. And you can see all the data was within 2 nanograms. So this is perfect for a screening tool. It costs $14 to buy these, and then we use them. And we use them with our protocol. And I'll talk about what we've done. But in our study, when we used Dentamedica, 82% of our subjects were deficient at the start of implant placement, and 100% of them after supplementing for 4 weeks before surgery, 2 weeks after surgery, reached the right doses. And 35% of our individuals were deficient in some form of antioxidant. So a lot of deficiencies out there. And like I said, we try and get these patients optimized prior to surgery. So the protocol that we do is typically for 6 weeks for most of our patient. We give them supplements 4 weeks prior to surgery. They take it in the morning and they take it in the evening. And then we also give it to them 2 weeks after surgery. Okay. We do this for all of our implant cases, bone grafting cases, periodontal cases, and soft tissue grafting cases. And now there's literature. I'm going to show a systematic review that I just found recently. There's evidence that supplementing patients, even for scaling and root planing, will lead to better outcomes if their vitamin D levels are higher. Which was quite interesting. So a lot of work's been done, and if you have questions related to that, certainly Dr. Estrin and I can help answer those. Great paper. I always like the work that Dr. Scott Froome does in his Perio Implant Advisory Board. He writes, easy to understand papers. I'll be completely honest, a lot of the papers that I write are, quite scientific. They're for high-ranking impact factor journals, but he's got a really nice way to take complex information and simplify it and get it out to the public. And he wrote one even before COVID here about how important vitamin D deficiency. We're talking 5 years ago. A guy like Dr. Scott Froome is supplementing all of his patients prior to implant surgery. I mean, this is somebody that's really, at the forefront of the field of perio. He's lecturing a lot all over the country and, talked about the rates of implant failure at 11% versus 2.9 when these patients are deficient versus at the optimal levels. And, we've published a lot. We published a nice paper here with Dr. Picos and one of my other good friends, Dr. Bashara, in Dentistry Today, vitamin D deficiency and early implant failure, what every clinician should know. And I don't often publish in such a journal, but a lot of people read Dentistry Today. And the editor was at one of my PRF courses one day, and he said, Rick, that stuff on vitamin D that you just showcase, it's so important. Do you mind writing an article for us, because we want to get this out there to hundreds of thousands of dentists so that they treat their patients a little more effectively. And we talked about the ability to do the scanning in your office. We talked about supplements. We talked about what range you'd like them in, and we also showcase failed cases that every person that placed a lot of implants has seen, right? Why is it that, in this case here, we've got great bone, we got bleeding bone, our implants go in, they look great on x-ray, and then 1 month post-op, it looks like an atomic bomb went off in this person's mouth. I mean, it's just complete destruction. What happened here? Well, what happened was this person was vitamin D deficient and, was not supplemented accordingly. And you lost these implants. These were the same implants placed the exact same way, bleeding bone, not osteoporotic, not diabetic, everything should have worked out. But that person, for whatever reason, had low levels of, vitamin D and issues happen thereafter. So, we've done a lot of work in that space to really understand this as best as we can. And this is the one that I find most interesting today, was actually published by a Chinese group, but they really showed an association of vitamin D in individuals with periodontitis. And it was a systematic review with meta-analysis, which is really the highest evidence base that we have. And what they did in their study was they looked at the impact of vitamin D supplementation on improving pocket depths and clinical attachment levels. And it included results from 16 clinical trials and about 1,500 patients. And what they showed was that if periodontitis was associated with lower serum vitamin D levels, so that we know already compared to normal populations, and it additionally showed that SRP plus vitamin D improved cal levels when compared to patients that were treated with SRP alone without supplementation. Okay. And this is quite interesting because they've shown in huge studies, 16 randomized studies, 1,500 patients, meta-analysis shows that if you simply do SRP and supplement your patients, you will get better results. I mean, it's proven scientifically now. So, now even our SRP patients, we're trying to get them on long-term use of supplements. And of course, we use the Dentamedica in those cases there. One of the things that Stella Life has done a really good job with is just optimizing. This is not just vitamin D. It includes all the cofactors, all the antioxidants that are needed. They've constantly been evolving the product and making it better every single year. It's gotten better, quite honestly. And I give them a lot of credit. Everything's made in US, non-GMO, GMPs. It's all vegan, gluten-free. It's all the things that you would want and all the highest quality products. And the nice thing is for our patients, the product is only $65 for a 6-week supply prior to surgery. And post-surgery in our SRP cases, they just need to take half doses. So it actually lasts 12 weeks. And so we give all of our patients these types of supplements and very, very highly recommended. So if you're not currently using this, I would recommend learning a little bit more about this specifically because it will have an impact. And like I said, the science now shows how important this is. So without getting into PRF just yet, which I'll get to right now, never forget how important, overall health is in your immune system prior to implant placement, bone grafting, or anything else that you're going to do. PRF, like I said, is something that we've specialized in. I think probably it's the thing that I'm most well known for. And, we really want to understand what we're doing in the PRF field. So we are going to capture, I always say we have an amazing intrinsic ability to heal ourselves, right? You or I, we can cut ourselves and we're going to heal. What's going to happen? A clot's going to form, cells and growth factors are going to get trapped in the clot, and over the next 21 or so days, we're going to heal. But as you age, your blood flow is starting to decrease, and it gets harder and harder to heal, especially places furthest away from your heart. And that's one of the reasons why when people have issues related to diabetes, for instance, they have issues at extremities. Typically, they'll get diabetic ulcers at the bottom of their feet. And the reason why is because it's the furthest place away from your heart. So it was Bob Marks who creatively said, let me draw some tubes of blood, let me spin them down, let me super concentrate and get that one layer where the platelets are. Those are the regenerative cells. Let's then take that and use that for regenerative purposes. Okay, so a lot of work's been done. We literally teach full day courses about understanding, at the, cellular, molecular level, exactly what's going on. But when we look at medical applications of this, it's quite amazing to see some of these cases, some that are very bad. I mean, these cases here, this is somebody that is diabetic. This is actually their Achilles area. This is their ankle. The foot's in the front there. And look at these diabetic wounds. I mean, this person is scheduled for amputation and they can't bring the appropriate cells to the area to actually heal. And so, one of the things that some of our medical colleagues are doing today is they're creating these super concentrates and they super concentrate the liquid PRF. And when it's liquid and not yet clotted, you always have to remember all blood will eventually clot. So we take them out, we put them in custom trays, we make the exact shapes that we want to, and then we'll then use this for regenerative purposes. So this right here is not just whole blood. This is a super concentrate of fibrinogen and thrombin that make a fibrin clot. And mixed in there is a super concentrate of platelets, which are going to help you regenerate, leukocytes, which further fight infection, and all the growth factors that are going to help with vascularization and healing. And this will literally be taken, placed over the areas, into the defects, etc., and healing will happen. So it's quite amazing. I've seen this gentleman here, Dr. Castro Pinto, treat many, many cases that were scheduled for amputation, and he's literally helped them heal. This is a nice video of what that looks like. So you're going to draw up the liquid PRF as you saw here. And once this is done, you're going to place it in the tray, whatever shape you want. You're going to wait for that to set. That'll take 10 to 15 minutes. Now you've created a biograft. And what he's going to do next is he's going to take this to the defect. And first things first, you can tell the patient's very diabetic, very white feet. Inject PRF around the periphery of the defect first. Once this is done, you're then going to take the biograft, bring it to the area, put a non-stick gauze pad over top of that, and then this will be after one treatment. Okay, so there it is. And healing happened 3 weeks later. Okay, so quite incredible to see. There's been a lot of evolution in this space. As I said, we cover, if people want to learn about PRF, Dr. Estrin and myself, we teach PRF courses, both for dentistry, facial, perio, I mean, whatever you guys want to learn in the dental space, at least, we cover it, but we also work with the U.S. Olympic orthopedic surgeon that teaches how to do joint injections. There's been a lot of evolution. We don't have time to cover all the protocols and everything, but our research team has done a lot of work in this space. I would say the most important paper that we've published in the breakthrough, a novel method for evaluating and quantifying cell types in PRF and an introduction to horizontal centrifugation. And for those that don't know what a horizontal centrifuge is and are not using it, what we've learned is that the fixed angle machines, the ones that are 45 degrees, they don't perform as well as the ones that actually swing out and are horizontal. When we actually calculate how the cells will travel in a tube, what happens is if this is my fixed angle and we start spinning very, very fast, we drive all the cells to the back walls. And then all the cells are on the back walls. They have a very hard time separating. So for instance, if you're a big, heavy red blood cell, you start up here, you start spinning fast, the cell goes boom against the back wall because the G-force drives everything outwards, and then it goes downwards against the back wall. If you're a little platelet and you started down here, you start spinning fast, you go poof, and then you're a light cell, so you're supposed to climb to the top. You're trying to go up, but you're trying to climb up this mountain when all these bigger red blood cells are coming down and blocking you from getting to the area. If that tube actually just swung out and was horizontal, then that little platelet can just walk a straight line instead of climbing up the mountain and get to the appropriate layers more effectively. Um, People have asked how much more effective that is to go horizontal, and that's what we've created in all the work we've done with PRF. But it's about 4 times more effective. So if you've never seen a horizontal centrifuge, they go in, the tube's still going up and down, but it'll swing out. So as this thing starts spinning and the G-force is created, the tubes actually swing out 90 degrees, and then you can get, proper separation. So there's a lot of advantages here. Bigger difference between the RCF min and max of the tube. Different ability, better ability to actually separate things properly on a fixed angle. It always goes like this, but the other way, horizontally, it's a perfect horizontal line across and horizontal perfect separation. And last but not least, I think this is the slide that really showcases whenever you spin on a fixed angle, you push everything against the back walls, you can no longer separate, and horizontally, you get much better separation that way. So this is literally, 8 to 10 years of research that we've done, kind of summarized in 5 to 10 minutes, but very, very important for those that want to do this. And that's the website for those that would like to learn more. And we have a lot of papers there, publications that can be downloaded so you guys can read that. And as I mentioned, 4 times more platelets and leukocytes, a lot of advantages in growth factor release and some of the other things. This right here is a slide worth noting. I'll keep it here for a little while because after, doing research in this field for 15 years now, these were the most optimized way that we will create PRF. And if you're a dentist in the room, you're going to be primarily focused on the solid PRF protocol. That's your 700 G-force for 8-minute protocol. That will make both your solid and liquid for making sticky bone and other things. If you need to have just a smaller amount, more concentrated, that's our liquid PRF protocol. That we use for facial aesthetics, and that's the protocol we will use there. And for joint spaces, we typically use the fast one and we take the buffy coat area right there. So for anybody that does TMJ joint, shoulders, knees, etc., that's the protocol that we would use there. We have a lot of videos, and if people want to send me emails, etc., to learn a little bit more about this, I'm happy to help you guys out. I don't want to cover too much of the PRF because these are Dr. Estrin's videos here, but when we use PRF, and what we're showing here is how you can use PRF in implant dentistry. And the way that this is done is, we always pass PRF through the abutment. Oops. And what that's going to look like is the following. We pass the PRF, cut a little hole through it, and then we are going to prevent bacteria from entering into the roughened portion of the implant, especially, but trying to prevent the bacteria stay outside, basically, and use this. So we've done a lot of work. A lot of people have helped develop this technique. Dr. Estrin will certainly show some great videos of its use. The one thing that I will say that we've learned, and especially doing many PRF courses, is how important the rinse that you use post-op is in these procedures, because as you can see here, yes, PRF is going to help a lot with soft tissue healing, but if I use a product in the oral cavity like chlorhexidine that's going to kill cells, this will destroy this very flimsy fibrin clot. So in these cases here, very, very important. Done a lot of work in this space, a lot of papers, also very recent ones, and looking at how peri-implant mucosal enhancement using PRF under the poncho technique, that's what it's called. They've done randomized clinical studies now and shown really that you'll get, an extra 1.5 millimeters of peri-implant mucosal thickness, and also increase the width of keratinized mucosa. So it's a great technique. It doesn't cost that much money. because like I said, once you have a centrifuge, a PRF tube is $1 per tube, so you can easily draw two tubes for $2 and do this. But very importantly, the antiseptic rinse that you're going to use becomes critical in these cases. These are not recent papers. My team have published this with one of my postdocs, Kasaku Sawada. I'm the senior author here. We actually looked at four different types of antiseptic rinses that are used, especially in oral surgery: iodine, 0.2% chlorhexidine, 1% hydrogen peroxide, and 0.25% sodium hypochlorite. And amazingly, every single one after a 10-second rinse killed 50% of the cells or more. And so every one of these is very bad for cell viability. And of course, when I learned about Life some years ago, and I learned from Dr. Michael Picos, I took it right back to my research lab to do a little bit more testing in this space. So we've published this paper looking at the cytotoxicity and gene expression changes that happen chlorhexidine versus this novel Life product. And what you see here is a live dead assay. 10 seconds, the cells that are rinsed with Life stay alive. The ones with chlorhexidine are already dying. And what I did next was I literally started to dilute the product, the final concentration to these levels. So, chlorhexidine is 0.12% chlorhexidine. This is 0.1% of that. So this is in essence is like 0.0001%. And I started to look at what is the cell survival. Okay, the cell survival is good. When it's diluted 100-fold, the cells still stay alive. When I dilute it tenfold, the cells start dying with chlorhexidine. And so even if I use 0.012% of chlorhexidine, it still kills cells. So you have to be very, very careful when you use PRF not to use something so toxic. That's something we've been doing. We've done a lot of research with this. Inflammatory markers go up dramatically. And I was very excited to see this study as well that was published a couple years after mine, comparing also, chlorhexidine, also using the Life and even Perioscience. And out of all of them, it was the VEG, which stands for Life here, that performed the best. So that's something that we use very, very frequently in the practice. And I'm sure Dr. Estrin will cover this in a lot more detail. This is my email right here. I'm going to stop sharing my screen, but if anybody has questions related to any of the protocols, etc., or want more information or some of our papers on vitamin D deficiency and or the Life papers, you guys are free to reach out to me. My email is rick@themironlab.com. So Dr. Estrin, I'll let you take it away now.
Okay, thank you. Just a little bit about me. My name's Dr. Nate Estrin. I went to Lecom Dental School, and at this point, I had no interest in being a periodontist, let alone a researcher of any kind. But I ended up falling in love with the specialty, and I went to Stony Brook University for my perio residency. And besides the weather change, I took a much deeper focus into research, and that's due to Dr. Georgios Romanos. And for those of you who don't know him, he's a periodontist, prosthodontist, and oral surgeon. So this is who I worked under for my 3 years in residency. And we published a lot of papers together, primarily focused in lasers, and that paved the way for me to come to work with Dr. Richard Miron. And at the time, that was at Lakewood Ranch Dental, and which was really close to Lecom. So it was such a coincidence to go back to where I went to dental school and work with Dr. Miron, one of the best in the field, and one of the leading researchers in periodontics. Um, Going from not really using PRF at all in residency to using it every day in clinic, I was just shocked at the results that I was getting, and couldn't believe that I hadn't used it before. It was such a game changer for me, and I feel very lucky to have started my career using PRF. Um, Working with Dr. Myron and PRF EDU, I would spend my weekends going to other practices, primarily general dentists, and helping them apply the latest protocols in PRF in their practice. So it was a lot of fun because for someone like me who just started my career in private practice and in clinics, I'm going to different offices and I'm teaching them about PRF, but I'm also learning a lot about, you know, little clinical pearls here and there, things that they do with patients, lines that they have with staff, etc. So it was just an amazing opportunity for me and, a great fortuitous start to my career. So I would be in clinic 4 days a week and then fly out to a different office helping them out. And then it evolved to going to universities and training perio programs and teaching them how to use PRF, specifically extended PRF, which I'll get to later. And it led to reconnecting with an old friend of mine, Dr. Ganesan. He's the program director of Iowa, and working with Iowa, becoming adjunctive faculty. I actually just took my Iowa dental law exam last year, so a lot of hoops to jump through to become faculty there. And now I can continue my research endeavors with the residents at University of Iowa. So very excited to start that. So PRF is just it's amazing and it's very easy to explain to patients. If you get a cut on your hand, or you get a dental implant or anything, the first step in wound healing is that a blood clot forms. Okay, so every patient has an intrinsic ability to heal themselves. And if they're too sick to heal themselves from a cut or a wound, then we really, shouldn't be treating them. They have bigger problems. Uh, so every patient to me is a candidate for PRF. We don't do PRF on cancer patients because we don't want to spread cancerous cells anywhere. But besides that, it's amazing to draw a patient's blood, spin in a centrifuge. And when we do that, all the cells separate based on molecular density. And we can take a super physiological dose of the patient's own platelets and white blood cells and a super concentrated clot and put it right at the wound site. Um, so the goal is to concentrate cells. Okay. And there's been a lot of advances in PRF. And when I go to different offices, a lot of people use PRF incorrectly or they use older versions. But it's very important to understand these advances. First of all, the removal of anticoagulants. So if you have PRP, the difference between PRP and PRF is that PRP, the tubes are coated in anticoagulants. So what it does is it inhibits the blood clot from completely forming, and therefore we miss out on a lot of regenerative potential when we're using platelet concentrates in clinic. Okay. And then Dr. Miron talked to you guys about improved centrifugation protocols. Like he said, it's about 4 times the concentration of growth factors with a horizontal centrifuge compared to a fixed angle. And me being a traveling periodontist at the start of my career, that's something that I recognize going clinic to clinic and being at clinics that used a fixed angle versus a horizontal, we didn't get as good of results. And also, if you want white blood cells, you really need a horizontal centrifuge because white blood cells and red blood cells are very similar in molecular density. So you need a horizontal centrifuge to accurately isolate them. Okay, then we have improved tube technology. A lot of the older tubes would have silicone in them, and so it would cause a pro-inflammatory response when you would take your PRF with silicone particles and put it right into the surgery site. Okay, so with BioPRF, we have, very clean, sterile tubes with no additives, no pro-clotting factors or anything of that nature. And then we have cooling and heating to control the clotting time and resorption time of PRF. So it's come a long way. If you want a really nice summary, this article, Optimization of Platelet-Rich Fibrin by Dr. Miron, was published last year in Perio 2000. It's one of the top cited top cited articles in the journal last year. And it's giving an amazing summary of these recent advances and why PRF of today is so much more advanced than PRP and then older versions of PRF. Okay, so here's just an example. You can see the silicone particles that are found in the older tubes, and that's why a lot of clinicians would maybe get okay results or not amazing results with PRF. So with BioPRF, there's 3 protocols that we can use depending on what the circumstance is. For me, being a periodontist and only doing dentistry, I only use liquid PRF and solid PRF, and I only have one setting, and that's 700 Gs for 8 minutes. And the reason for that is because I want to optimize my protocols for solid PRF. Now in my practice, I've got one centrifuge, okay, and a lot of assistants are coming in needing to be trained. And for simplicity purposes, I just want one setting, and that's 700 Gs for 8 minutes, because solid PRF, again, is my bread and butter and my workhorse in dentistry. And I'll get to that in a second now. So let's just talk about the difference between solid PRF and liquid PRF. So with solid PRF, you have hydrophilic tubes. Okay, so the platelets stick to the walls and the clotting cascade is initiated, and so you end up with a nice vibrant clot with growth factors entrapped within it. With liquid PRF, we have hydrophobic tubes where the platelets don't stick to the walls. So what happens is that clotting cascade is delayed and PRF stays in liquid form. Okay, and this is important because you can use liquid PRF as an injectable. So a lot of clinicians that I would visit, they would use solid PRF and they would actually use PRP with anticoagulants so that they could still inject it. But they're again missing out on huge regenerative potential. And our group actually just published a systematic review comparing liquid PRF to PRP, showing that liquid PRF has so much more regenerative potential than PRP. Okay, so let's talk about what the role of fibrin is. And if you know how long a growth factor lasts for, okay, it's not hours or days, it's actually just minutes. So on average, about 6 to 12 minutes. So if you have a growth factor, you inject a growth factor all over the surgery site, you have 6 to 12 minutes of working time where it either binded to the cell wall, cause it to proliferate or differentiate, and then that's it. But when you have solid PRF, you have this fibrant clot with growth factors entrapped, and as it degrades over time, it releases its growth factors. So you have 6 to 12 minutes of working time over and over again. 6 to 12 minutes, 6 to 12 minutes. Okay. And this is extended release concept is something that we see in nature with drip by drip infusion or titrated IVs or extended release medications. It's similar to if you're watering a plant and you take a bucket of water and you dump it on the plant at once, you're not doing as much good as if you watered that plant a little by little every day with the same amount of water. Okay, so that's why solid PRF is such a workhorse for my clinic and why you can really observe the regenerative potential more. If you're new to PRF or you haven't used it, the best way to appreciate the increased healing is with extraction sockets. Um, so because extractions heal by secondary intention, can really appreciate the accelerated healing. This is just a simple extraction of number 4. Patient is getting a partial denture, not interested in bone grafting or an implant. So I just use a piece of solid PRF alone as a solo biomaterial. It's actually not the standard of care for implant dentistry. The standard of care is still to use bone particulate. You'll regenerate less bone with PRF than bone particulate, but more bone than if you did nothing at all. But besides that, you also get the accelerated wound healing and patient comfort when you use PRF. This is just 2 weeks later. Patient said this was the best extraction she ever had. She couldn't believe it. And this is just the healing that we get pretty routinely in our practice. Here's another case from last year. This is just extraction of number 30, solid PRF alone. And 2 weeks later, you can appreciate almost complete healing with the chromic suture still in place, still yet to resorb. So just really accelerated healing. And why is that? That's because we are using clean tubes, horizontal centrifuge, ideal protocols, and maximizing our regenerative potential by using solid PRF. Okay, the standard of care for implants is I use sticky bone where I mix bone particulate with PRF, and I'll get into that later. So here's just a simple extraction site of number 19. Looking back on this now, I'd probably do an immediate implant, but that's okay. If you use solid PRF as a membrane alone, what happens is when it resorbs 2 weeks later, if you don't have complete coverage, you're going to have your bone particulate be vulnerable. So I do a double layer with a collagen membrane and solid PRF. Okay. I use a lot of chromic suturing because with PRF, you get such accelerated wound healing that you don't need anything more than chromic, and it makes the post-op appointments a lot easier for you and the patient by not having to do suture removal. And here, 2 weeks later, we've got pretty much complete closure. Okay. Moving on to surgical periodontal therapy. Um, I use PRF instead of when I was doing osteosurgery, instead of scraping autogenous bone, I just fill my vertical defects with pieces of solid PRF. And even in a case where I've got horizontal bone loss, after I do my osteosurgery, I'm taking little pieces of solid PRF and packaging it into the embrasures. So you'll see here that my assistant has little pieces of PRF cut up on the tray for me. And every time I'm doing osseous, if I have a defect to fill, I'm filling it with solid PRF. Okay. Or if it's horizontal bone loss, again, I'm packing into the embrasures. Why? Because you have analgesic effects with PRF. It heals much faster. The patient can get to brushing faster. They feel normal faster. And by their 2 week post-op, they're back to normal home care in between. Okay. And there's actually a lot of studies supporting the use of PRF in intrabony defects, showing that it's comparable to when you use DFDBA or bone particulate. Okay, and this is exactly how I would do it non-surgically. So one of these studies that we are just wrapping up in our clinic is how far you can push the limits with non-surgical therapy. So I did a lot of research with Dr. Romanos at Stony Brook. Now I'm focused on combination laser therapy using both Nd:YAG and erbium YAG. Nd:YAG for soft tissue and erbium YAG for hard tissue. And then different additives after combination therapy like Emdogain, PRF, Arrestin. You think of how much Arrestin does, imagine trapping that in the PRF. And since PRF is in liquid form, we have the ability to add biomolecules of our choice into the PRF while it's liquid before it clots. Okay. And this is actually a systematic review that our group recently did. This is a forest plot. I just want to draw your attention to group 5, which was the addition of biomaterials and biomolecules to PRF. So what we showed is that a lot of these research groups are taking biomolecules like statins, bisphosphonates, vitamin C, metformin, and trapping it into the PRF while it's in liquid form before it clots, and then using that in their periodontal therapy. And what it showed was that PRF plus a biomolecule was superior than PRF alone in all these studies. So it's amazing the research potential with PRF because we can actually use it as a delivery vehicle where it's 100% autogenous. We're trapping a certain drug or biomolecule, and we get that extended release effect where we're releasing the patient's growth factors along with any biomolecule we want. I'll skip this video. This is the poncho technique. I do it a lot when I'm placing immediate implants. What better to have a wall of the patient's own white blood cells surrounding the implant platform than to leave it vulnerable or with a collagen membrane and to get that accelerated healing. And Dr. Miron talked to you guys a little bit about Life. I'll share my experience with Life. Okay, a lot of clinicians would be using chlorhexidine with PRF and not getting as good of results because the chlorhexidine is killing off all their cells. Okay, so if you use PRF, you can't use chlorhexidine. You have to use something like Life that's selectively cytotoxic. And what I mean by that is that it has antimicrobial effects, but it doesn't kill off our own cells. In fact, the study that Dr. Miron just showed you guys showed that you have increased fibroblast migration and collagen expression. So not only is it antimicrobial, but it also helps with our own wound healing. And patients kept asking me what's in Life, and that led me to write this review article breaking down all the active ingredients in Life and how those active ingredients and those properties have been maintained in the final Life rinse. And I'll just share my favorite, which is Azadirachta indica. If you look on Google Scholar, Neem has had a lot of publications behind it. This was actually the Village Pharmacy as one of their nicknames. It was called the Tree of the 21st Century by the United Nations in 2017. And there's over 300 phytochemicals that you can isolate from neem trees. And if you actually look for, certain sprays or antifungal sprays for your plants, neem oil is a very popular one that you'll see. This is the plant that in ancient India they would use to clean their teeth. They would use neem twigs. So what I tell my patients is that this has essentially been used in the oral cavity longer than modern toothpaste and mouthwash. Okay, and it's actually being used or being researched as a cancer drug because of how many different pathways are involved. Cancer is very complex. You need a lot of different pathways to treat it. And neem, being that there's so many different phytochemicals you can derive from it, is being researched as a potential cancer drug. I'll just share one case example. Like I said, I was a traveling periodontist. This is one of my cases from the office where I wasn't working with Dr. Miron, so we don't have, PRF or any great biomaterials. This is just a ridge augmentation case at number 30. I just used bone particulate and a collagen membrane, and you can appreciate my suturing. And this is just really a sloppy case. If you look, my sutures are pretty loose, and my bites are too shallow. And being that this is a thin tissue phenotype, what happened is that 2 weeks later, we had a soft tissue dehiscence and the patient was freaking out. She thought that this was bone, and I told her, no, that's the membrane, but it's not good that we have this exposure, and you're probably going to lose the graft, but I'm going to redo it for you. And of course, you feel terrible when you don't get a good outcome, especially when it's because of your technique. Um, and she really didn't want to redo this, and she's like, please, is there anything that I can do, anything at all? And I said, well, I'm writing this paper on still life, and it's supposed to help with fibroblast healing and et cetera, and it's worth a shot, but I still think we're going to have to redo this graft. So she ordered still life online and rinsed with it, and 2 weeks later we had complete closure. And this is without PRF or anything else. This is just still life alone. So this is what made me really appreciate the power of cell life, specifically in wound healing. And an early mistake of mine in my career was able to be covered up because of cell life. So the case was successful after this. You can appreciate how thick the ridge is, and that we've got complete closure just 2 weeks later. And so this goes without being said, but all the cases that I'm going to show you, I didn't use chlorhexidine at all. I used Stella Life. Okay, back to PRF. I want to talk to you about soft tissue grafting. Okay, and it's funny because I learned this technique from Dr. Cantor, and after dedicating the last 7 years of my life to research on lasers and PRF, when I would go to these in-office trainings, everybody was most excited to hear about sutureless free gingival grafting. Okay, so this is a case a lot of you probably see in your practice. We've got very little keratinized tissue. Mandibular premolars are a very common place. All I did was do a horizontal incision at the mucogingival junction and distal vertical release to create a recipient bed. Um, I went through a phase where I was harvesting a lot with a piquette blade because it was very fast and easy, and a lot of general dentists like to do it this way. But I do a lot of different cases and feel like I have more control with a 15 blade, so I did switch back. But after you harvest the free gingival graft, you can actually just fasten it into place with cyanoacrylate alone. So I place cyanoacrylate all along the coronal border and the lateral borders and apply a periodontal dressing so the patient doesn't play with it. Okay. And this is a great indication for PRF. The palate, when you harvest a free gingival graft, heals by secondary intention. Okay. So before you fix the graft into place, you can cut a piece of solid PRF to a similar size and fasten it to the palate. Here I use sutures. I got away from sutures, and I'll go over that pretty soon. This is 2 weeks later, the healing on of the palate. This actually isn't that great compared to a lot of other cases that I have. The recipient site looks phenomenal at 2 weeks. It's completely healed, patients back to normal home care, and this was done completely sutureless. This is a case for uh, clearance for orthodontic therapy. Patient had a thin phenotype and prominent roots. Okay. Because I've had so few patients complain about the palate when I use PRF, I started doing larger and larger free gingival graft cases, and I harvest my connective tissue grafts the same way. I de-epithelialize the palate with a burr, and then I harvest my connective tissue graft like a free gingival graft because I have a lot more control and I get a much thicker piece, and with PRF, the patients rarely ever complain, especially when you use PRF in a stent. Um, but here I'm just using it to remove the rugae for my free gingival graft. So again, I have liquid PRF where I'm soaking my grafts into place and I cut pieces of solid PRF to the appropriate size. And what you notice is now that you've exposed that liquid PRF to oxygen, it will start to clot much faster. And so you'll have this, solid PRF now forming on the intaglio surface of the graft. And I really believe that this is the key to this technique being so successful. A lot of the times we suture to close the dead space between the graft. What's better to fill that dead space with than PRF? A super concentrated dose of the patient's own growth factors and blood clot. It's really made this technique a lot more successful. Again, here I sutured the PRF to the palate. Okay, same ordeal. I'm just using cyanoacrylate to fixate my graft into place and putting periodontal dressing. And here I've got 2 weeks later, complete healing. And here's the palate at 2 weeks. Okay, it's not a sexy procedure by any means. You can see a lot of fancy suturing with connective tissue grafting, but those take a lot more time. When you're not suturing these free gingival grafts, they're done very, very quickly, and it's very easy and not technique sensitive. And we actually um, just got a case series accepted for publication in the International Journal of Periodontics and Restorative Dentistry of over 100 consecutive cases. I've only been doing this technique for the past 3 years, and I've yet to have one failure. It works extremely well. It's more predictable than implants or anything else that I'm doing because it's a soft tissue graft with PRF and our fixation method is reliable when you use PRF, periacryl, and periodontal dressing. So this was actually just recently accepted. Um, the PRF was actually made for the palate. What I noticed, this is a video, this is just a few minutes after the surgery. So I placed PRF on the palate. I go to the recipient side and fixate my free gingival graft in place. And what you notice is just after a few minutes, the blood flow stops because you're putting the patient's own blood clot onto their palate. So it's going to adapt. And I stopped suturing the palate completely. I would just place PRF on the palate like so, and you can see how stable it is. And then I would put a stent over top and have the patient wear the stent for 2 weeks. And that was all I needed to do. For time's sake, I'm going to skip this video, but it's very similar to me just placing PRF on the palate and using a stent over top. This was actually an article of ours that was also just recently accepted in Journal of Periodontal Research. It's a narrative view where it has that video and it shows why PRF is so beneficial for palatal wound healing. Okay, so just to go over the two types of PRF, I use it for, pretty much every dental procedure, extraction sites, either as a solo graft or as a membrane, in non-surgical and surgical periodontal therapy, poncho techniques when doing second stages. I place it under every incision line that I do, whether I'm doing GBR or a sinus lift. Repairing the Schneiderian membrane, it really comes in handy. It's like taking a wet paper towel and throwing it against the window. It sticks really well, and especially if you have a minor tear, this is really all you need. And my favorite indication, donor sites for soft tissue grafting. Okay, and to talk to you about sticky bone, there's a lot of different ways to make sticky bone, and a lot of ways are conflicting. There's actually a study by Fang in 2021 that published the optimized way to make sticky bone, and that's by taking solid PRF and cutting it up into little pieces because it forms a nucleus for your bone graft material. Then after you add your bone, you drown the area with liquid PRF and it sticks together, and it had the most mechanically stable properties out of all the different ways to make sticky bone. I won't do a lateral window sinus or GBR without it. Even if a patient declines, I just won't do the lateral window sinus because it just makes the procedure so much easier. You can appreciate if you had a tear or anything going on in the sinus. What better than to have sticky bone that stays together? It's like a putty. It's a lot easier to handle, and it's actually makes the procedure a lot safer. It's so much easier to do. Anytime I'm doing, something simple like an extraction socket where the patient declined bone PRF, and I'm just using dry bone particulate, I think, how did I ever, use this in the past? It's just a much messier procedure. Okay, so I want to talk a little bit about exosomes, just a brief background. Exosomes are extracellular vesicles, a nanometer in size. It's about 1/1000th the size of the cell. Okay, and it used to be believed that it was just um, plasmatic dust or waste of the cell, but what it actually is it's cellular communication. So these exosomes have little messages of microRNA, proteins, lipids trapped inside them, and they have the phospholipid bilayer of the cell included. And so it's signaling for cells. Not all exosomes are created equal. You can get exosomes from different sources, but it's another way to have proteins and lipids that will aid in regenerative potential, again, depending on the exosome source. Okay, and you can actually mix that in with your PRF. There's actually not a lot of literature supporting the use of PRF for hard tissue formation. It's mostly soft tissue. So what better than to find exosomes with specific proteins that will aid in hard tissue formation and mixing that in with your PRF. Okay, we just published a review in Perio 2000. There's already 113 articles published on exosome use in dentistry. Okay, and since this was published last year, I'm sure there's 100 more. This was one of the hardest reviews and papers that I've ever been a part of because as we're writing it, there's more papers on exosomes being published. So this is really a hot topic because the regenerative potential with exosomes is just so massive. Here we have a schematic illustration. This is one of the studies they did in a mouse model where they would have a ligature-induced periodontitis model. So they would put a ligature or a foreign body in the periodontium of these mice. And in two of the groups, they would inject it with certain exosomes from different sources. And what they found is that there was very little breakdown in the exosome groups, despite having a foreign body in the periodontium. I just think like how amazing to just inject the periodontium, and have no breakdown despite a foreign body. It was wild because all 113 articles gave overwhelming support to the use of exosomes, which is something that you don't see. You don't even see that with the PRF literature, despite us knowing that it works so well clinically. So this is a ridge augmentation from 28 to 30. This patient was actually on my schedule for implant 28, and I had to change gears. So when you're a traveling periodontist, sometimes there's a little bit of chaos in your scheduling. But here I'm taking periosomes, which are exosomes that help promote bone formation and being used in dentistry. And I'm mixing that in with my sticky bone and letting it clot within the sticky bone complex. Okay, so here I have my full thickness flap reflected, and you can appreciate I've got maybe 2 millimeters max of ridge thickness. And here I just put the sticky bone on the buckle of the ridge, and you can just appreciate the space maintenance that you get with sticky bone. Just putting it in place, it holds its shape pretty well. And I'm securing it with a collagen membrane. There's no tacks, no nothing. I'm just securing it with periosteal tacking sutures. And like I said, I put solid PRF under every single incision line. And here's my primary closure with EPTFE. And 11 days postoperatively, it looks normal. We actually took a CBCT at each month. So this is just after a little bit after 3 months, we started to see the bone shrink. So I decided, to go in and place my implants. I placed a 4.6 diameter at number 30. Can appreciate how much wider the ridge is. And you can see a little bit of space between the implant and my osteotomy. And that's because I took a core sample. To me, this looks like a face, but I sent it to the histopathologist that I used to work with at Stony Brook, and he couldn't believe how integrated it was for 3 months. And he actually asked me, "Are you sure this is, 3.5 months?" And I said, "Yeah, it's only 3.5 months." I couldn't believe it. Um, what was amazing is that at 6 months, we actually had more bone than we had at 3 months, despite me, I didn't add any bone at all at the 3 month implant placement. So if you look at the CBCT scan, radiographically, we actually have shrinkage of the ridge from 1 month to 6 months. Okay, if you appreciate that. But clinically, from 3 months to 6 months, we had a gain in bone. So all that particulate that you see here in the flap that's not integrated became integrated later. And it showed up radiopaque on the radiograph, and that's why you can see that ridge have the same thickness, but then it actually converted to bone, and the bone quality is amazing at 6 months. And this is due to the extended release. So exosomes have this phospholipid bilayer that makes them less susceptible to breakdown. So you get this extended release and working time over a period of months as these membranes break down. Um, and what you guys just saw was actually the first ever case in humans. And this was also accepted for publication in IJPRD. And hopefully you guys will see it in print this year. We're waiting on the proofs. So back to two types of BioPRF, okay? And while solid PRF is the workhorse for everything I do, again, that's from the extended release, liquid PRF provides all the opportunity. So liquid PRF can remain as an injectable form, okay? It can become solid PRF. If you introduce oxygen, heat, time, it will turn into a solid clot. Okay. It has the ability to trap biomolecules like exosomes or any biomolecule of your imagination. It can help solid PRF clot faster. Sometimes if you have a solid PRF tube that doesn't clot, you can take some of the Buffy coat zone, which is the intersection of the red and yellow, and introduce more platelets to the solid PRF and make it clot faster. That's just a clinical pearl of mine. And it can produce extended PRF. Okay. And I love extended PRF because it's how I got this job working with Dr. Miron. Extended PRF, what you do is you heat the liquid PRF to 75 degrees Celsius. And so you have an extended release or a resorption time of 4 to 6 months. Um, when you do that, you've killed off all your growth factors and cells. So the genius of extended PRF is that you draw two blue tubes, one that you heat up. Okay, so you get the 4 to 6 month resorption time, and one that you don't, and you mix the two afterwards. So you actually trap these growth factors from the unheated tube into the heated gel with a 4 to 6 month resorption time. And it's being used as a biofiller. Dr. Myron teaches a lot of courses in facial aesthetics and using ePRF as a biofiller. And then he was looking for a research-focused periodontist to join him in clinic and do research on using ePRF and perio. Okay, and so here we have these are animal studies showing the 4 to 6 month resorption time and the release of growth factors during. And here I've got an ePRF membrane. So after you make this gel, you can put it in a tray and let it sit to a membrane of your shape. And it's a similar consistency to cooking an egg. And it's a very similar process. As you heat it up, all the albumin proteins denature and it makes this gel-like consistency. We've published these cases in Perio 2000. Here's just a ridge preservation. Here's my ePRF membrane in place. I have it sutured with chromic gut, and 8 days post-operatively, we have pretty accelerated healing, and the membrane's still intact. Okay, here's another case. This is actually 2 weeks post-operatively, and we have almost complete closure. This is with an ePRF membrane alone. Again, just to reiterate, solid PRF would resorb too quickly over the course of 2 weeks, but ePRF, we have 4 to 6 month resorption time. So as long as it stays in the mouth, it can be used as a solo membrane. Okay, here's another case showing, great bone formation, and we could place our implant right away. Here's a video of me using the ePRF membrane, and you can appreciate it looks like Jello. It feels like Jello. I'm not that confident when I'm using this membrane, and after waiting 15, 20 minutes for it to set, it starts breaking apart on me as I'm putting it into place. Okay. So I'm not feeling that confident about this case. I asked the patient to come back for a 2 week post-op so I can, see the results of it. And he says that he is a snowbird, and the best that he can do is come back in 4 days because he's leaving for Minnesota. So 4 days later, he comes back, and you can appreciate, um, the membrane is intact. It actually continued to clot and stabilize after he left the office, and it looks really good for 4 days. Um, I'm not sure what the plan is for number four. I haven't seen the patient in a while, but that will probably be next. Okay. Here's a case series we just published with Dr. Hussein Basma. This is actually his case. He takes amazing photographs. This is an ePRF membrane that he used to repair the Schneiderian membrane inside the lateral window sinus. And here he's got his ePRF membrane afterwards. Um, and I'll share one of my cases. This was actually a case that was sent to me. By a professor of mine from LECOM that I was trying really hard to get him to see me as, the periodontist that he refers to instead of his former student. So this is actually the first case that he ever sends me. This is a lateral window sinus at number 2, and you can probably see several things wrong with this case. We have a Sieber class 1 ridge deficiency, or excuse me, class 3 ridge deficiency, meaning that we have lost both height and width. There's no keratinized tissue, and it needs a lateral window sinus. So I try to talk the patient out of it and, ask him, like, do you really miss this tooth? Do you really want to replace number 2? And he said, Dr. Zaki told me that you're the guy to do this. And if you're not, then you send me to who is. So, perfect time to do a research case. So here I've got my lateral window sinus. I've placed my implant with sticky bone, and you can appreciate that I don't have 2 millimeters of buccal wall. Here's my ePRF membrane. It's really thick and chunky, and you can appreciate there's really no ridge augmentation whatsoever. I didn't do anything but put this ePRF membrane on the buccal of this ridge and sutured with single interrupted sutures. Okay, Dr. Zachary actually did the extraction site before sending it to me. And this was 6 months later, and I couldn't believe how thick the buccal wall was. We've got plenty of bone growing over top of the implant, and a lot thicker tissue than when I started. It looks like almost a completely different ridge. And so the theory is that if you have this thick ePRF membrane that's going to resorb over the course of 6 months, you have this extended release where growth factors are being resorbed from the membrane, and you're going to generate hard tissue on the hard tissue side of the membrane and soft tissue on the soft tissue side of the membrane. But, we need a lot more evidence. Right now, I just have my cases and case series that I'm working on, and that's one of the reasons why I paired up with University of Iowa so we can further study these ePRF membranes, and hopefully do some more histological studies to find out how it works a lot better. Here you can use, I'm using ePRF as a matrix for soft tissue grafting. So this is actually a split mouth case. I'm using ePRF on one side, okay, and solid PRF on the other, and you can appreciate it's breaking apart on me, similar to the extraction site. All right. Um, and so here we've got half and half ePRF and solid PRF. Here's 2 weeks postoperatively and 2 months postoperatively. This is actually a lot of things are working in our favor for this case. We have a thick phenotype, a good amount of keratinized tissue. This would have worked with any really biologic. You can see on the solid PRF sign, we didn't get complete coverage of number 6. That has more to do with the fact that 5 was extracted for premolar reasons and he had a big bony defect on the distal of 6. So, I can't really attribute that to ePRF outperforming solid PRF. Here we've got 2-year follow-up showing that it's well maintained, but we've got a lot of things working for us in our favor. You know, um, the biggest problem with ePRF is that it takes a long time to make. It's not really practical with the way that we practice in modern dentistry, especially me. I used to be a traveling periodontist. I worked for a lot of corporate offices. It was really, really hard to do this type of dentistry in other offices. And that's where I struggled with, not just the technique itself and doing it at other offices, but whether I want to continue doing clinical research. Is this where the rubber meets the road and I switch to becoming just a full-blown clinician? Um, and it just takes too long. So you've got centrifugation for 8 minutes, okay, bioheat for 10 minutes, all right, 15 minutes of setting time. That's about 35 to 40 minutes of working time, and imagine you take a tooth out in just a few minutes. Are you going to wait 35 to 40 minutes for a membrane to set when you have other patients waiting and you're pulled in other directions? I'm sure every dentist that's listening can relate. It was really, really difficult to do that. So then the idea came to use ePRF as a biofiller, right? And not wait for it to set, if it's breaking apart anyways. So here's another case. Again, I'm doing the Vista technique, vestibular incision. This is number 11. The patient didn't want me to take from their palate, which is okay. And so here I am coronally advancing and suturing the flap um, with chromic gut. And I'm closing before I put any biomaterial at all. And I'm actually coming in and using ePRF as a biofiller to fill the site. And here you can appreciate that the ePRF is actually just spilling out of the sulcus. And at the 2-week follow-up, I actually wasn't that happy with it because I thought we could have gotten 100% coverage if I used a connective tissue graft. But what was amazing was at 3 months, we actually had creeping attachment, which is something that you observe with autogenous grafting, like a connective tissue graft or regingival graft. Okay. And at the 1-year follow-up, all right, we had maintained coverage, and you can appreciate it's a much thicker phenotype than when we started. All right. Um, and then I moved on to extraction sockets. This is actually a patient that I brought in, did a little in-office experiment. I took out number 12, grafted it with sticky bone, used a chromic suture, and no membrane at all. And then I came in with the biofiller so that I skipped the waiting time for this ePRF to set. All right. And you'll appreciate my assistant is going to suction the excess of the ePRF right here, like so. Okay. And then I apply a little bit more. And then every 15 to 20 minutes, I would check on the patient and see how stable the membrane was. And these photos will do it justice. Here is immediately after application. Okay, here is 30 minutes after application and 60 minutes after application. You can appreciate the membrane is starting to set and stabilize. Here is 2 days postoperatively, and here's 2 weeks postoperatively. We had complete coverage, similar to the other ePRF membranes where I wait around 20 minutes or so for it to set in place. Okay, here's it, extraction number 18, and my ePRF membrane in place. Again, it looks like a gel. I'm not that confident in it. Similar to the sutureless free gingival grafting, it makes you like maybe a little nervous at first. 4 days post-operatively, the membrane's still intact, and here's 2 weeks later, we have pretty much complete closure. It looks great. And here is another case, number 12. I'm using ePRF as a membrane, and the healing at 2 weeks looks pretty good. Now, every time I'm using EPRF, for the most part, I'm using it as a biofiller. Here's a lateral window sinus where I'm using EPRF as a biofiller and covering the lateral osteotomy like so. Okay. Other uses of dental phlebotomy, to bring this back to AOSH, you can imagine I'm doing PRF on all my patients. All my assistants are phlebotomy certified. And patients were always asking me, can you test my vitamin D? Can you test my glucose? And almost jokingly. And then I finally thought, why can't I? And in Florida, you actually don't need a CLIA license. So I called Quest Diagnostics and they sent me a free centrifuge. And so now I can start doing blood testing on my patients. So I would do a fasting glucose and fasting lipid panel and check their vitamin D. Um, and we've only done about a dozen cases so far in my office. I've switched offices. We've had to restart this program. But what was amazing was a lot of these patients were either pre-diabetic or diabetic. A lot of them were vitamin D deficient, and they didn't even know it. And if I wasn't doing this blood testing, I would just do a surgery on them, and that was it. But they would get sent to their general dentist, or they would come in for, a chief complaint, pain, or of somewhere. Their general dentist would see that they have perio and send them to me, and they're walking around, they haven't seen their physician in years, and they're pre-diabetic. And so, this isn't really a new concept at all, doing blood testing in a dental office. Obviously, patients see dentists a lot more often than they see their physicians. But, it's hard to get a dentist that doesn't do any PRF at all and say, hey, do phlebotomy in the dental office and start doing more comprehensive care for the patient. But for an office like mine that does a lot of PRF, and a lot of other perio offices and oral surgery offices that I know that do PRF every day, it's really no problem for them to get their staff that's already trained and to start doing medical testing. So, really, once I finish my current PRF research, I really want to focus on, a lot more oral systemic health, and doing a lot more medical testing in my office. That's where my future's headed. So, really excited about that. It's a much, much more powerful conversation when you come into a patient and you say, hey, you have periodontal disease, you're also pre-diabetic, you also are vitamin D deficient, you're on track because of your lifestyle. If your lifestyle doesn't change, you're going to head to a wrong direction. It's a much more powerful intervention when you have that conversation with a patient. So, having phlebotomy in the dental office, improved wound healing and outcomes, I really can't imagine not doing PRF in my office. If a patient declines it for price or whatever reason, I just do it for free because it just costs dollars, tubes and a butterfly needle. And then the patient comes back and they have a good experience, and they're gonna, send their family members and friends to you. Improve diagnostic and more comprehensive patient care, because, you can actually diagnose patients medically and get a lot more information for them. So thank you for listening. I know it's really late on a Wednesday night, but, hope you guys got a lot out of it. Um, and that's all I have for you. Feel free to reach out anytime with any questions.
Thank you so much. That was great. We actually do have a couple of questions that came in, and I want to make sure that we get those to you. Someone asked, all the research I'm reading on vitamin D relates to needing K2 D3 combo. When we are recommending vitamin D, are you recommending that combo for best practice?
Yeah, I can certainly answer that. The answer to that question is absolutely, without a doubt. Most importantly, though, if you just do vitamin D and K2, that's a standard 12-week protocol. So the one thing that I'll say is, like, you can't just go to Costco and buy a vitamin D K2. The advantage of Dentamedica is that it contains not only higher quality vitamin D, but also all the cofactors. So people don't know how important, like, manganese is, magnesium, boron. So there's all the other cofactors as well.
Yeah, absolutely. So I actually use Stelloph's vitamin every day. I have for a while now. I'm a gastric bypass patient. and was struggling to get up levels, vitamin D in particular. And since I've started on the Stella Life vitamin, and I can say this, and they're not paying me to say it, I'm saying it because it's the truth. My vitamin and all my blood works come back perfect. It's gotten to the point now where my vitamin D is actually a little too high, and I'm having to back off. I've been taking a regular regimen. I'm having to back off and go to a half dose of the
Mhm.
Stella Life vitamin. So it's the first time in ages that my gastric bypass surgeons come back and said, Violet, your blood work is actually good for once. So they were really thrilled to see that. So it really is a difference. And I was taking, the Costco vitamins and, doing the best I could, and it just wasn't getting me there. So I'm really proud to say that my blood work looks really good, and it's
Yeah.
because of
And
Stella Life's vitamin.
yeah, to further add to that, it's extremely important to use, GMP standard vitamins. So made under good manufacturing practice. So that's something that I know Stella Life has greatly improved. And also the source of vitamin D really makes a huge difference as well. So I know that they've put a lot of research into that. Another thing that I will say is that we're not too sure what the right levels are for vitamin D. So when you say you were too high, like some people will say, like if you're 61, you're too high now, right?
Yeah.
Overdose is it's over 100.
Yeah.
It's almost
Mine was at like
impossible.
84. So I
80,
was,
so you
yeah.
were probably too high, yeah. So
Yeah.
that's worked
A
out well,
little
though. I
too much.
mean,
Yeah.
that just
So
goes
we
to show
backed
you,
off a little.
yeah. In our study, actually, when we did the study, we put everybody on Dentamedica, and every single patient within 4 weeks was within the right range. Nobody was below 40 in 4 weeks.
Yeah. It
And the
didn't take
benefit of
long.
it, yeah, you just do the dose in half and then, you're good forever. And the nice thing is not very expensive, right? So
Yeah.
it's, you now have a $62 bottle that's going to last you 12 weeks, 3 months. And
Yeah.
it's very, very high quality. So they did a really nice job with that.
Yeah, I was dropping at least $70 a month on all of the vitamins that
Oh,
I
I'm
was taking.
sure.
So
I'm
yeah,
sure.
so it was. So we also had a question. We currently use OraCare and activated chlorine dioxide. Any research on this or thoughts?
No. And the minute you say chlorine right away, we know that's going to be very, I don't want to say dangerous for cells, but it's definitely going to have some negative effects on cell types without a doubt. So, I always say our jobs in medicine is to practice things as evidence-based as possible, and that's not one that's very commonly tested. So I've read a lot of a lot of literature in that space. That would be one that I would guess would have pretty detrimental effects when you combine that with PRF, so I wouldn't do that.
Yeah. So next question, could you kindly compare and contrast exosomes relative to PRF use in dentistry? Are there certain cases where you would involve both or do one before the other? And if so, for what reasons?
Yeah, Dr. Estrin, you can answer that one.
It's best when used in combination. So PRF will be a matrix to contain the exosomes. And of course, exosomes are going to give it a lot more regenerative potential. So you would use in a case where that's applied. But technique and surgical technique is also like very important for every case that you do. And no matter what biomaterial you use, you need to make sure you follow the surgical principles and do a good surgery to have a good outcome regardless.
Yeah, and to further add to Dr. Estrin's point, you know, PRF is great for practices, there's no doubt. And a lot of people have been using it for many years. So a lot of people think like, oh, how can we get anything better than this, right? I would say, based on our initial work, the potential and properties of exosomes are, 4 to 6 times more regenerative than PRF is. So when you really need that extra boost, like there's no chance Dr. Estrin could show the cases that he showed on, ridge augmentation in 4 months. You would never be able to do that with PRF ever. So it's all about just speeding healing. I'm very close as well with U.S. Olympic orthopedic surgeon Robert Talick, and he's now reporting to me that when he treats professional athletes, they're healing typically 50% faster when he combines the PRF with exosomes. So it makes a big difference. If you want your patients to heal faster, etc., that's the way to go.
Awesome. So the next question is, do they wear the stent 24 hours or take out to clean, rinse, etc.?
They wear for 2 weeks straight. I tell them to eat with it, and they can take it out and rinse it out after a meal if they need to, but then they put it right back in their mouth.
All right. So, to what extent can PRF replace connective tissue grafts and soft tissue augmentation procedures around implants? And what are the long term aesthetic and functional outcomes?
That's to be determined with a lot of research. Obviously, if used in conjunction with connective tissue grafting, it's going to accelerate healing. You're not going to gain a keratinized tissue when you use PRF or ePRF. So if you have a case where you don't have enough keratinized tissue, you might want to use an autogenous graft.
Yeah, and to further add to that, our research team performed a big systematic review on that topic, and it was determined that PRF can replace basically biomaterials. So, for instance, when you would use collagen membranes, instead of using collagen membranes, you would use PRF or ePRF, even better in those cases. But when you're missing a 2 millimeter band of keratinized tissue, just like Dr. Estrin just said, then you absolutely need to get a connective tissue graft or free gingival graft in those cases there. So for those that want to learn more about that or ever asked the question, there's actually a paper where we have an entire like protocol diagram, do this if this happens, do this if you have this, and it illustrates when to use it, when not to.
That was actually me. I'm getting ready to have a bunch of work done in here, so I was
Ah,
just
well, that's
yeah.
Dr. Estrin. You got a new
Yeah.
patient.
Well, I'm
Welcome
I'm
down to
getting ready to
Sarasota.
have a mouthful of implants done, so I was very curious about the zirconia implants too, because that's really got me kind of worried because I just literally financed a car in my mouth a couple of days ago, so to start my bone grafting and stuff. So that's it's got me a little worried. So you'll be hearing from me, Dr. Esther, about that. That's both of you, because I'm kind of worried now because I actually have already a mouthful of zirconia crowns in my mouth. So I'm a tad bit worried. So I'll be in touch with you about that. But we'll
Yeah,
make it. We'll
one,
figure it out.
to add to that, I would say that the zirconia implants are going to work better longer term, but
Mhm.
short term, the osseointegration is a little bit slower than titanium. Okay,
Okay.
so like if I was placing implants in my mom, it would certainly be zirconia. I would just know that it's going to take a little bit longer to get osseointegration. The most important thing is that your vitamin D levels are like perfectly optimized before you do surgery, and you maintain those levels, forever basically.
Okay.
And I didn't show the studies, but there's literally studies 1, 2 years post implant placement, even 2 years later after your implants are placed. If your vitamin D levels drop, your bone around your implants drops as well.
Yeah.
So this is something, particularly in your case, you're gonna have to monitor pretty closely for the rest of your life.
Yeah, and I have to anyways because I mean I get blood work done every 6 months anyway, so I
Perfect.
have to keep
Yeah.
eyes on all of it to make sure my health is where it needs to be. And then the last question we had, can Dr. Miron and Dr. Estrin talk about any additional factors that come into play to ensure the greatest success for severe periodontitis cases compared to early periodontitis cases? So,
You have to solve all the etiological factors. So you got to look at that case and see what's going on. Like Dr. Myron talked about, making sure that they're in an anti-inflammatory um, immune system, not pro-inflammatory immune system. So obviously their diet and lifestyle play a huge role. But you have to look, do they have excursive occlusal interferences? Is it a hygiene problem? You got to look at all the etiological factors, all the reasons, and solve those reasons one by one. And with a severe perio case, it's usually more than one, two, it's usually more than three. So I would look at everything and solve each one. But that's
Yeah,
um,
to
criteria.
add to that too, it also depends on the depth of the pocket depths basically. So, Dr. Estrin is doing some really awesome work right now comparing, just doing standard scaling and root planing versus doing that plus lasers, plus PRF, plus PRS and exosomes. There's a case series study that he's comparing 6 groups. And I always tell patients, it's like, if you go to a dentist or across the street from us, they just get old school scaling and root planing. If you come to our office, you're getting scaling and root planing, laser therapy done perfectly, PRF with exosomes mixed in, and then that's going in your pocket. So you're giving somebody a much better chance to regenerate the tissues even before you do surgery. So that's always a first step as well.
and then there was someone reminded me. I'm very sorry, Michael. I apologize. I just saw this question. There was one question on what was the shortcomings of the liquid solid PRF and the exosomes. What are the shortcomings of those? Basically, was the question. So,
Uh, I don't know if you had that in your slides, Nate, some of the shortcomings. I could talk about all of them, but a lot, I would say the shortcomings are, um, a lot of times with the solid PRF, you cannot use it alone. So a lot of times you have to combine it with connective tissue graft or biomaterials, et cetera. So, we can't think that it's a miracle product. Um, and so that's where we always try and develop, agents like extended PRF or like other things. I don't really see too many shortcomings with exosomes, quite honestly, apart from the price. They're $195 each. So the cost goes up dramatically compared to PRF. But again, the regenerative potential is much higher. So,
Mm. And just to add to that, we don't use PRF on patients that have active cancer.
right. Yes, good point.
And like I said, technique is more important than biomaterial. If when I look at my cases, any negative cases that I had, it's never because of PRF or exosomes. It's because of my suturing or, something that I did wrong or the patient did wrong. So that really, all those play a role as well.
Absolutely. So I'm going to have Danielle come up here and go ahead and put up the QR code for today's webinar and share that with everybody. And she's going to talk about, there we go. She's going to talk about how you get credit today and how everyone is going to receive credit for the webinar.
Yeah.
She's going to share that with everyone.
So it's super easy, actually. Since you've been here, you can get credit. AOSH members get to see these credits on their transcript. So if you're not currently an AOSH member, you need to be able to collect it. If you are an AOSH member and you stayed at least 90%, I do the rest. So your attendance is verified through Zoom, and then you will get a confirmation email in a couple days.
So, and we will, I'm traveling right now. So guys, please know that, as soon as I get off the road here, I will have this up behind our membership paywall and you will be able to view this webinar, be able to go back. And I know that, both Dr. Estrin and Dr. Miron are going to provide their slides and the information, and we'll try to get that out to you just as soon as we can as well. Give me just a little bit of time. I will be home on Friday. I have been up since about 3 o'clock this morning, so I plan on leaving this webinar and going to sleep, hopefully. So that's my goal as soon as we're out of here today. So we have been doing some pretty extensive traveling. So yes, we will see that you get a copy of the presentation. Michael, thank you very much. But I want to thank both of our advisory board members. Thank you both. One, for your service to AOSH. We are so grateful and very thankful for you. And then secondly, for being willing to do this webinar for us. We are always grateful for the new technologies, the new information that's out there, the things that are coming down the road that are literally going to change how dental care is healthcare and how we're going to save lives in so many new and different ways. And you guys are literally on the forefront of this. You're literally on not the cutting edge, the bleeding edge of technology, and we love to see these things. And I know that our members love it as well. It's something different. It's not just these same things that we talk about oral systemic health all the time. It's literally the diversity and the change and the ideology that we need and the things that we need to be talking about. So I thank you very much for your willingness to present tonight, and to work together as a team like this has been really cool to watch and a lot of fun. So it's great. You two are fabulous, and we appreciate you both.
Thank you. Appreciate it.
So, guys, we have more webinars. All you have to do is go to aosh.org, go up to our menu, and click on our link for events, and you will see tons of upcoming webinars. You can choose and select from just about anything you're interested in. We hope you're interested in all of it, and that you'll join us for our next webinars that are coming up. Don't forget to get your ticket for Dallas. We thank you all for joining us tonight. There's no more questions. I think all hearts and minds are clear. So God bless you. We appreciate you. We love all of you as members. Thank you for joining us, and we will see you again very, very soon. Take care. Good night, everyone. Have a great evening.
Good night, everybody.
Bye.
Bye.